Akira Miyauchi at Kuma Hospital, Kobe, Japan. I'm talking on active surveillance for papillary microcarcinoma. Papillary microcarcinoma is defined as papillary carcinoma 1 centimeter or smaller. Some of them may have lymph node or distant metastasis, invasion to vital tissues, or aggressive cytology. These are high-risk papillary microcancers, should be treated appropriately. However, vast majority have none of the above. They are low-risk papillary microcancers. During the recent 3 decades, thyroid cancer increased rapidly in many countries, mostly due to increase in detection of small papillary cancers. Papillary microcarcinomas became nearly half of the recent thyroid cancer series. Although thyroid cancer increased, mortality from thyroid cancer remained stable. Therefore, many researchers suggested overdiagnosis and overtreatment. How should we manage patients with papillary microcancers became a very big clinical issue. The facts are high incidences of latent thyroid cancer in autopsy studies and a similar incidence of thyroid cancer in a screening study using ultrasound-guided fine needle aspiration. These instances were more than 1,000 times the prevalence of clinical thyroid cancer. With these huge discrepancies, I had a hypothesis that most papillary microcancers would remain small. However, some of papillary microcancers will grow. The issue is how we can identify the minority that progress. I thought observation without immediate surgery will tell the answer. Doing surgery only for those that show slight progression would not be too late. Doing surgery for all papillary microcancers might result in more harm than good. With these considerations, I propose an observation without immediate surgery clinical trial at Kuma Hospital in 1993, 28 years ago. This trial later became being called active surveillance. We made a diagnosis with ultrasound-guided fine needle aspiration. For high-risk papillary microcancers, we recommended surgery. For low-risk papillary microcancers, we proposed observation and surgery, and patients chose one of them. Patients who chose observation were followed with ultrasound 6 months later and once a year thereafter. We recommended surgery if the tumor shows disease progression. These figures show risk of active surveillance according to the location of papillary microcancer. If it is solitary and surrounded by thyroid tissue, it is an ideal case. If the disease is multiple or adhering the thyroid capsule, attaching the trachea with acute angles, or located near recurrent laryngeal nerve with a normal thyroid rim, these are appropriate cases, can be candidates for active surveillance. However, a tumor adhering the trachea forming obtuse angle or located near the recurrent laryngeal nerve without a normal thyroid rim, these are inappropriate cases. We should recommend surgery. During active surveillance, at 10 years, 8% of the patients showed tumor enlargement and 3.8% of the patients showed lymph node metastases. Very interestingly and unexpectedly, unlike clinical thyroid cancer, papillary microcancers in patients under the age of 40s were more likely to show disease progression than in middle-aged or elderly patients. Multivariate analysis for disease progression revealed that only young age was the significant factor, and family history for thyroid cancer and multiple disease were not significant factors. During this 8-year period, more than 2,000 patients with low-risk papillary microcancer were seen at Kuma Hospital. 45% of them underwent immediate surgery and 55% chose observation. 8% of them had conversion surgery for various reasons. Small number of patients in the both surgery groups had local recurrence, which was successfully treated with salvage surgery. During the study period, small number of patients in the both groups died of other diseases. Very importantly, more than 1,000 patients were alive without disease progression, and there were no distant metastases and no death due to thyroid cancer. Therefore, oncological outcomes of these two management modalities were similarly excellent. However, if we look at the incidences of unfavorable events such as temporary and permanent vocal cord paralysis, temporary and permanent hypoparathyroidisms, patients on levothyroxine, and patients with surgical scar, these were definitely higher in the immediate surgery group than in active surveillance group. We calculated total cost of management for 10-year period according to the actual flow shown previously. We found that the total cost of immediate surgery was 4.1 times the total cost of active surveillance. Well, patient point of view or emotional issue are important. Louis Davis conducted a questionnaire survey for patients on active surveillance at Kuma Hospital. Very importantly, 83% of the patients replied that choosing active surveillance was the best decision for them personally, indicating they were satisfied with the management. With studies on quality of life in patients with papillary microcancer comparing active surveillance and immediate surgery, on thyroid cancer-specific health-related quality of life, the immediate surgery group had poorer scores at several issues than active surveillance group. And on hospital anxiety and depression scale, the immediate surgery group had poorer scores at anxiety and depression than the active surveillance group. In summary, oncological outcomes of the immediate surgery and active surveillance were similarly excellent. However, the incidences of unfavorable events were definitely higher in the immediate surgery group than in the active surveillance group. And the medical cost of immediate surgery was 4.1 times the cost of active surveillance. In addition, patients on active surveillance were satisfied with active surveillance, having better quality of life than those who underwent immediate surgery. Therefore, we can say active surveillance is much better than immediate surgery for patients and also for the society. At Kuma Hospital, currently we recommend active surveillance as the first-line management for the patient with low-risk papillary microcancer. Cancer Institute Hospital in Tokyo started active surveillance from 1995, 2 years later than Kuma Hospital. Their outcomes were quite similar to those at Kuma Hospital. With the promising results from these institutes, the JAES Guidelines 2010 accepted active surveillance for low-risk papillary microcancer. This became the first guidelines that accepted active surveillance. 2015 ATA guidelines for adult patients with thyroid nodules and differentiated thyroid cancer adopted active surveillance management as an alternative to immediate surgery. The JAES guidelines revised in 2018 now actively recommend active surveillance. You know, doubling time is a well-validated way to analyze and express tumor volume kinetics over time. However, it has two major limitations. First, if some of the tumors decrease over time, the doubling times for these cases are given in negative values, which creates problems of discontinuity from the positive values. Second, the magnitude of doubling time is opposite to the magnitude of growth rate. If we take inverse of doubling time, these limitations are resolved. I propose calling this index doubling rate, since it indicates the number of doublings that occur in a unit time. Using doubling rate, we were able to show the tumor volume kinetics of papillary microcancer during active surveillance. Positive values indicate tumor growth, and large values indicate rapid growth. Negative values indicate regression. During active surveillance, only 3% of patients showed rather rapid growth, 22% showed growth, 57% stable disease, and very interestingly, 17% of the patients showed decrease in their tumor volume over time. This figure was shown previously. In this cohort, 8% of the patients on active surveillance had conversion surgery. We looked at this issue. During this 12-year period, more than 2,000 patients chose active surveillance. 7.1% of them had conversion surgery due to disease progression, patient preference, physician's preference, surgical indications for the associated thyroid or parathyroid diseases, and others. When we divided the period into the first half and the second half periods, we found that the conversion rate in the second half period decreased to about 1/3 of the first half period. A subset analysis on conversion reasons showed a similar decline in conversion rates in the second half period for all reasons. The real-world clinical approach for patients with low-risk papillary cancer is unknown. Thus, we conducted an email questionnaire survey for 1,178 JAES member institutes in 2018. Only 134 institutes responded. However, 72.4% of thyroid cancer cases were operated at these institutes, so actual coverage is quite large. As the current management policy in these institutes, almost all of them offer choices among active surveillance and immediate surgery, and 26% of them recommended surgery, while 31% of them recommended active surveillance, and 39% of them offer the choices without specific recommendation. In this institute, 576 patients with papillary microcancer were seen during a recent 3-month period. 54% of the patients chose active surveillance. So, active surveillance is becoming popular in Japan. The Memorial Sloan Kettering Cancer Center and Korean team produced a thyroid cancer treatment choice pamphlet to facilitate patients understand the treatment options. They responded that patients exposed to this pamphlet were more likely to choose active surveillance than those who were not. Here is a simple tip to help patients choose how to manage their papillary microcancer. This is a leaflet on papillary microcancer currently used at Kuma Hospital. Giving the leaflet after finding the aspiration result is not good. Giving it before performing finding the aspiration greatly help patients to choosing their management. Warner and Ingber's The Thyroid 11th edition was published last year. We are very glad being invited to write a chapter on papillary microcancers. If you need more information, please read it. Thank you for joining this symposium.